I'm Dr. Keith C. Ferdinand, and welcome to this conversation among friends. We're going to be addressing the disproportionate burden and disparities with COVID-19. Our panelists have already presented, and now you get a chance to hear some of their thoughts going forward about the pandemic. We have Dr. Takesha Davis from New Orleans, Dr. Lana Morris from Atlanta, Dr. Yvonne Commodore-Mensah from Baltimore, and Dr. Kevin Alexander from Stanford. Dr. Davis, let me ask you first. I know you personally, and I know you're doing great work in the community. What's going on in terms of the work you're doing? Are you seeing a lot of hesitancy or uptake of the vaccines?
Well, we are still seeing hesitancy in groups like our working class, our minority population, based upon not just the historical racism in the American healthcare system, but also just in the challenges with access. So what we've done here at New Orleans East Hospital is really taken to the streets. We've taken our mobile units to churches, to community organizations, now in partnership with McDonald's, going to places where people go anyway, whether that's for food, fun, or worship, and giving them access to the vaccines right where they need it, and hoping that we can convince those who are hesitant that this is our best shot at getting back to normal.
You know, unfortunately, the southeastern states are good for football, but bad for cardiovascular disease. And now they're bad for the uptake of the COVID-19 vaccine. Dr. Morris, you're in Atlanta, and I know Louisiana's not doing as well as we should. How are you doing in Atlanta? What type of barriers are you seeing there?
Yes, I mean, I like to say that Atlanta's a little bit of an oasis in the state of Georgia. I know I'm biased because I grew up in Atlanta, but I think that we see oftentimes in the United States that cities are not necessarily representative of what's happening in the country, because there tends to often be a difference between what's happening in cities versus what's happening in rural America. I think you're right. I think what we've seen, particularly recently in a lot of the southern states, is some particular sort of issues related to mask mandates, things related to COVID, the COVID passports or vaccine passports, and sort of some directives coming from on high that, in my opinion, as a scientist, as a clinician, I think many of us would agree may not necessarily be the best way to get us completely out of this pandemic, right? We know in many ways, of course, we understand that, many of our local politicians want there to be a separation in terms of politics. However, we of course want to do what's right in terms of science. We want to get ourselves out of this pandemic, right? That should be the focus. And so of course, we've seen that many of us are still wearing masks. I personally am still wearing a mask because I have a 5-year-old and a 4-year-old daughter who are not eligible for a vaccine. And so even though I myself have been vaccinated since December as a healthcare worker, I have 2 children who are not eligible to be vaccinated. And so I wear a mask everywhere I go still to this day, because I feel like that's an important thing for my daughters to see until they can be eligible for a vaccine. So I think there's still a lot of mixed messaging. I think that's confusing people. And I think I myself am just continuing to do best practice. And until I feel safe in every environment that I'm in, I continue to do what I think is best practice, which is hand washing, mask wearing. And I don't mean to sort of belabor this point, but again, when you listen to the statistics, which of course are saying that over 50 to 60% of adult Americans, somewhere in that range, have received at least 1 dose of the vaccine. That varies wildly based on the state that you're in. And you started by mentioning the Southeast. Many of the Southern states are not in a situation where you're talking about 60% of adults. I've heard estimates where in some of our states, it's like 1 in 10 adults, or 1 in 20% of adults have actually received the vaccination. And so you have to think about that when you just take your mask off and say, I'm free. If you're in a situation where only 10% of the adults around you have actually been vaccinated, you may really be putting yourself at risk again by acting like you're
I don't think you're too cautious. I also continue to wear my mask. And probably as we go into the summer, we're going to see some people who are going to fake it. They're going to say they're vaccinated and not. You just don't know. You're going to the shopping center, or you're going to a food mart. You just don't know that person behind you, whether or not they are truly vaccinated. Dr. Commodore-Mensah, you're a little bit up north or up south. I'm not sure where Baltimore is. I guess it depends on your politics. What are you seeing there in Baltimore?
Right. So generally in Maryland, we're fortunate that at least 45% of the population has been fully vaccinated, and about 70% are either partially or fully vaccinated. So I think we are doing better relative to other parts of the country. But as has been alluded to, we know that there are disparities in who has been vaccinated, particularly Hispanic populations in the Maryland area have lower vaccination rates. But the other challenge is that in our neighboring Washington, D.C., and we know that these boundaries are artificial, right? About 80% of the infections that have shown up are among African Americans or Blacks, right? So as we talk about vaccine hesitancy and increasing uptake of vaccines, we have parts of the country where we're not doing a great job, right? And although the vaccine is available to anyone who wants to get it, we know that there are, I call them 3 buckets of people: people who simply don't want the vaccine. It doesn't matter what you tell them, they don't want it. But there are people who haven't gotten it yet because it's not convenient. They haven't found a time that works for their schedule. But then there are also people who don't have enough information. And I think the last 2 groups are easier to address. The first group, we just have to give them time. I believe we shouldn't write anyone off. There are people who change their minds, given time and given more information. But for those who don't have access to it because of scheduling, like Dr. Morris said, we have to think about, and Dr. Davis also said, we have to think about ways to bring the vaccines to them, right? So making the vaccines available where people worship, where people shop, where people work, right? So that it's convenient. And then for people who lack information, we have to provide information that is understandable and make sure that we have the right messengers who deliver the message to the community. And I know that at least, for instance, among the Latinx population, the Kaiser Family Foundation has embarked on an initiative or a campaign to reach Latino and Hispanic persons, and they're engaging healthcare professionals, including physicians, nurses, community health workers who are from Latin America, to make sure that they reflect or represent the population. But we are making progress, but we still have a long way to go to make sure that everyone is vaccinated.
Dr. Davis had addressed what you just said. She called it taking it to the streets with a mobile van in New Orleans, going to where people are. And it doesn't appear that it's just fixed locations. It sounds like it's also fast food places or wherever. So, Dr. Davis, I'm going to ask Dr. Alexander what's going on the West Coast, but I'm going to come back to you to talk about how you think we can use these novel ways of addressing the community in terms of vaccine access. Dr. Alexander, you're way on the West Coast, the best coast. What's happening out there?
Yeah, I mean, I think it's a story similar to what we've heard from my colleagues. I think overall, the state of California has a higher vaccination rate than a lot of areas in the country, but there's huge heterogeneity when you look at the Bay Area versus, say, the Central Valley or outside of major metropolitan areas. Even within the Bay Area, I think if you start to break it down by demographics, there's still huge disparities in terms of who is getting vaccinated. And so, I think that the important thing is our work's not done, that there's still a lot of vulnerable people that need to be vaccinated. And I think the initial efforts we had to get people out to educate and vaccinate is terrific, but now there needs to be more targeted approaches and figuring out kind of what some of those barriers are, like Dr. Commodore Mensah kind of mentioned some of those, and really address those to try to increase reduce the hesitancy and increase the willingness to get vaccinated. So I think that's kind of where we are. At Stanford, we're really, because it's like a lot of the medical centers we practice at, we have community, the main health center, but also community practices that are kind of more embedded in these areas. And so we're really trying to figure out how to work together with our community practice physicians to reach these patients.
Now, I've been to Stanford, and I know it's a wonderful institution, but aren't there some areas, I think, on the eastern side where people really are disadvantaged?
Exactly right. And, in the last few years, Stanford has more of a presence in the East Bay. So there's some Stanford-based practices that are out in the East Bay and North Bay now. And those are precisely the folks that we want to engage with and work together with. So I myself have talked to some of the primary care physicians and general cardiologists out there, not just about COVID, but other disparities in the Black community, particularly for heart failure. And so we're trying to figure out partnerships to address, these different areas.
All right, Dr. Davis, I promised I was going to give you another opportunity to describe exactly what this van does. How do you do it? What vaccine are you taking out? Are you able to keep it at a temperature which is acceptable? What's the logistics there?
Absolutely. So going out to mobile locations, whether it's a fast food restaurant or church or a place of employment, does take some logistical planning. And I'll start first by saying it's so important for us to recognize the importance of partnering with a community-based organization in our communities that can actually spread the message and the narrative about the safety and efficacy of the vaccines from trusted voices. Oftentimes, as hospitals and providers, we are not the trusted voices that those who are hesitant to get the vaccine want to hear from, but they want to hear from their pastor. They want to hear from their beautician, their barber, that this is safe. And so we have partnered with community organizations that actually go and knock doors days before, share information where we will be in the community, provide incentives that are meaningful to the community if we can. And that could be anything from a coupon to a local store or a free barbecue plate or a free fish plate, whatever gets people to come outside to do that. And as we are planning on the provider side to ensure that we have choice, which we haven't had before. And we've all talked a lot about get the vaccine that's available to you. Now that we have ample availability and access to vaccines, we are able to bring out vaccines to the community more than just one choice, because we do have community members who want single dose Johnson & Johnson, but single dose Johnson & Johnson is not right now licensed, right, to be given to those down to the age of 12. And so we have to think about ways on how we get that vaccine out to our community members. So we are able to bring out Pfizer and Moderna to those locations. We do talk to the sites prior to, so that community members have knowledge prior to what's coming into my community. It'll be Moderna and Johnson & Johnson or Pfizer and Johnson & Johnson. It's not quite have it your way like some of our fast food restaurants, but it's close. And I think that helps with the trust in saying, now I have the information, I can make the best choice for me and my family and have that vaccine administered right in my community. So we have been.
How do you keep the vaccines at an acceptable temperature?
So with the Pfizer, which is the biggest challenge, obviously, in keeping the vaccine at an acceptable temperature, it's about the scheduling, right? Because we've got the 5 to 6 hour window of when you take that vaccine out of the freezer to be able to use it. And so we actually plan with our team, if we're going to be out vaccinating between, let's say, 10 to 2, that vaccine is not being removed out of the freezer and brought to that site until 9. And then we've got to get folks there to get vaccinated. And it really does take the planning, making sure that you have the ability to keep the vaccine cool on site, but that you're not removing it prior to and losing those hours, particularly for that Pfizer vaccine. That has worked well. We've been able to go around our community and working in conjunction with those community organizations and scheduling. But the partnership is so important in sharing of information in our communities, where we know there's a lot of reason for hesitancy in our marginalized communities. Last thing I'll say is that I think this is a strategy that we've used before in public health and going out door to door and providing education around certain disorders and providing access to mobile units, whether it's for breast cancer screening or for dental screening. But now we have the opportunity in this partnership to capitalize on these relationships and be able to come back and do screening for hypertension, for diabetes. And our hope is then to be able to move a step further and connect these communities then through telehealth, right in their backyard, on the corner, to providers. So not just screening, but then saying, hey, you can have an appointment with your cardiologist next Friday. The unit will be here, and we can help to bridge some of the digital divide that we also have.
I'm gonna come back to you at the end, Dr. Davis, but I wanted to ask some of my panelists, one of the questions that we had formulated before this discussion is, what are you going to do to deal with this tail end of the pandemic? And I think the question might be a false choice, because I'm not as convinced as some
we're
that
at the end.
Tail end. So I'm gonna get your perspectives on that, but let me go to Dr. Morris. What are you telling people about the tail end of the pandemic? And maybe you're going to tell me it ain't the tail end.
Yeah, I mean, I think, I look at the sort of daily reports, and certainly everything seems to be moving in the right direction. But again, we're starting to see these warnings, of course, as we come upon Memorial Day weekend, that we have to be careful. And I think that's exactly the right messaging. As soon as we start to get very excited as a country that we're in the clear, we start to see these peaks come back. I mean, I think that's what we learned from 2020. You heard me say earlier that I'm still wearing a mask, in part because I feel like it's just not that big of a deal, in my opinion. I'd rather wear a mask than deal with the sort of death and destruction that I've seen from COVID. And of course, right now I'm fielding questions from a lot of friends and family who are certainly interested in getting, for example, their teenage children vaccinated, but have heard, for example, the reports of myocarditis in the sort of younger, I think mostly men or young adolescent men who've received the vaccination. And I think that we're going to have to continue to field those questions. And I think we have to continue to remember that as a community, we are still learning when it comes to this virus, when it comes to these vaccines. All of this is new for us. One of the things that I say to my friends and family, as well as to patients, is that in my experience as a healthcare provider, as someone who's taking care of these patients, is I still would rather take my chances with the vaccine and the side effects from the vaccine than take my chances with the infection. And I think one of the things that I ask myself as a scientist and a clinician is, are the individuals who may seem to have some of the more robust, I guess, reactions to the vaccine, would those have been the same individuals who would have had a really severe reaction or infection if they had gotten infected with COVID-19?
Yeah, it's interesting for a person to try to divide out causality versus association.
Mm-hmm.
I mean, an unfortunate thing happens to a person and they happen to have gotten the vaccine 1, 2, 3, 4, or 5 days a week before doesn't necessarily mean causality. Would you agree?
Exactly. Absolutely. So I think, again, I think the message from my perspective is we have to continue to do best practice. And the interesting thing, again, sort of hearkening back to the masks, is we're focusing a lot on COVID-19. But again, when you look at the data related to influenza and many of the other viruses that we see circulating, we've seen a lot of benefits from a year and a half of wearing masks. It's not just benefits related to COVID-19. And so I think we've learned a lot in the last year and a half, even though many of us feel like we've sacrificed a lot of personal freedoms. I think we've also gained a lot as a society. And I think it just depends on what your personal perspective is.
Dr. Commodore-Mensah, are you hearing that message from your patients or any of your friends and family that it's over and they're glad it's over?
Actually, there's a camp that feels like, well, life is beginning to get back to normal. Right. But I think one of the things that's clear is that the pandemic will end, but COVID-19, unfortunately, is here to stay for a while. Right. And we'll have to adapt, just as the virus has adapted and we have variants. We'll just have to learn to live with it and take precautions. And we are also learning that it's likely that people who've been vaccinated will need booster shots. Right. And so in many ways, when we talk about vaccine hesitancy, it's not a one and done issue, right? But it's something that we'll have to wrestle with for a long time. That if people need a booster shot in 6 months, right? what's the strategy? What's the messaging? They've done it before. So how can we convince them to get a booster shot? So I think as we talk about hesitancy, it's important to remember that a year from now, if we have to get vaccinated, how do we learn from the strategies that worked this year and last year, and strategies that didn't work, right? How do we devise incentives? And I'm so glad Dr. Morris raised the issue of incentives. So in Maryland, someone is $40,000 richer today because they got vaccinated, right? So our governor came up with this lottery system, and by July 4th, someone's going to win $400,000. So if that's what it takes and we have the resources, why not? And in Ohio, the $1 million is at stake. So I think we have to devise ways to make sure that we continue to maintain a certain level of sort of the population that's vaccinated, right? But one other thing I think we should also consider is for those who didn't die from COVID-19 and have had COVID-19, dealing with post-acute COVID syndrome, right? So there are people who are living with some long-term effects from being infected with COVID-19. And so we have to think about the care of people with this syndrome and learn more about what it takes to improve their health, right? And I think when we talk about also preventing COVID-19, people think, well, if I'm not going to die, what are the long-term effects, right? So including that in the messaging, that it's possible that you'll survive, but there are people who are living with COVID-19, but are dealing with some debilitating symptoms, right? So people need to understand some of the reasons why we're sort of pushing for more and more adults to get vaccinated.
I'm glad you brought that up. In some of the cohort studies, it's been as much as 15 to 30% of persons who had COVID-19 had long-term symptoms, and NIH actually has coined a term for it, post-acute SARS-CoV-2 syndrome. We now know there's some professional athletes who are saying the reason they're performing so poorly is because they're short of breath and tired. And one of the NBA players, a star, now has to use an inhaler. So those are wonderful things that you brought up. You may not get hospitalized and die, but you can have long-term effects from COVID-19. Dr. Alexander, your take, is the pandemic over?
I agree with my colleagues that this is, I think it's important to be optimistic because we're certainly in a better place than we were this past winter. But, I think it's important not to take our foot off the gas. And, we've been through this cycle a few times before where things look like they're getting better and you can get flare-ups. And, I think some of the things that where there's uncertainty is when we fully open up, how that will affect transmission when schools are in person in the fall. These are things that, I think it's hard for anyone to predict how they'll impact the cases. And, viral illnesses tend to be worse in the fall and the winter. So, as we enter the summer, things look great and, everyone is relaxing. But how will things turn out later this year, I think is still kind of an open question. And so I totally agree that we need to continue the messaging that people need to get vaccinated and still do a lot of the things to reduce transmissions that Dr. Morris said that really, I think, should be something that are common practice, not only for COVID, but for preventing other viral illnesses. And so I think that it should become part of our new normal.
This panel is purposely diverse in terms of sex, geography, training, background, profession. But one of the things that I think we need to recognize that all of us live in cities where people come from all over the world. Even New Orleans, it's a small city, but we have 200,000 and 300,000 people a year come in. San Francisco is an international port. Atlanta, of course, the largest airport in the United States, and Baltimore is an international city. So I'm gonna start with you, Dr. Alexander. We don't have much time, short answers. This is the last question. What about the variants? People fly in, are bringing in variants. We know at this point our vaccines seem to be holding up, but I don't think America is an island. What do you think?
Yeah, I mean, I think that that's one of those uncertainties with kind of how things will transpire later this year. I mean, fortunately, so far the vaccines for the most part are effective against the variants, and there's a lot of data that if there are resistant variants in the future, that booster shots will likely, be effective in many cases. So I think it's something that can be planned for. And I think, that's something that we're going to have to contend with, but I think there would be ways to deal with it.
Dr. Davis, your take-home message, you can speak to the variants, but if there's something else you think is more important for our audience to know, please feel free.
Just wanted to amplify what my colleague spoke on, is that, while the pandemic may come to an end, COVID-19 is not going away. And we need to stay hypervigilant, adhere to our public health messages, because as schools re-enter into a phase of in-person learning across this nation, we will have hundreds of thousands of children who are not vaccinated in the classrooms. Without those measures, we may see, again, them being vectors of transmission. We may start to see an uptick. So we all should continue to practice those public health measures and not keep our eyes off the prize.
Dr. Morris, your take home, you can speak to the variants or anything else you think is really important for our audience to address.
Yeah, I mean, I completely agree with Dr. Alexander and Dr. Davis. I mean, I think in many ways, even if we're able to convert COVID-19 to a phenomenon that looks similar to, again, influenza, where we all, or many of us, get a flu shot every year to keep ourselves, sort of protected from a severe influenza infection. I think that's a win. And I personally am okay with that. Many of us in healthcare do that every year and are required to, and I think that's okay. And I think the other thing we have to remember is, we need to be prepared for the next pandemic. This is probably not the last pandemic that we will see. And I think many of us need to mentally, emotionally, and spiritually prepare ourselves for the next time we're in the situation, whether or not this is 2 years from now, 5 years from now, 20 years from now. This is not going to be the last pandemic that we see.
Dr. Kamano-Mensah, you have the last word. If you want to speak to the variants, that's great. But if you have something else that you think is more important, please let us know.
Sure, thank you. I think one of the lessons we must learn is that global health is local health. And just as we've learned that the virus is not a respecter of borders or boundaries, as we celebrate sort of the wins in the US and vaccinating the US population, I think we shouldn't forget about other countries, low and middle income countries that don't have access to vaccines. Because if we want to protect ourselves from the variants, we also need to ensure that other countries have or enjoy access to the vaccines that we've had. And that's the only way we can get to a state where life begins to return to normal. But if we continue to ignore sort of the urgency of supporting other countries that have limited resources, I think we may end up in this situation in a couple of months where there's sort of widespread variants in the US.
Thank you all so very much. You come from different parts of the country. You have different perspectives, but I heard the same message. It's not over, that we need to be diligent. We need to address the disparities, not only related to COVID-19, but racial ethnic disparities related to diabetes, heart disease, heart failure, hypertension. They're everywhere and they need to be addressed. They need to be eliminated. I'm Dr. Ferdinand for the Cardiometabolic Health Congress. Thank you for listening to our conversation.